Today we're going to talk about Hirschsprung disease. We'll cover the definition, presentation, diagnosis, treatment, and possible complications. Hirschsprung disease is a physiological or functional bowel obstruction secondary to motor disorder of the intestine and failure of intestinal relaxation. It's caused by failure of complete craniocaudal migration of neuronal crest cells during intestinal development. It happens about 1 in every 5,000 live birth. It has male to female predominance in about 4 to 1. The disease was described in 1880 by Dr. Hirschsprung, who was a pathologist in Copenhagen. He described two cases of Hirschsprung disease in patient who died with bowel obstruction. And he named it congenital megacolon. He's the first person to explain absence of ganglion cell as a pathological cause. Syndromes associated with Hirschsprung disease includes congenital central hypoventilation syndrome, trisomy 21, and MEN2 and ret oncogene abnormality. Presentation, they can present early in neonatal life with the neonatal bowel obstruction or delayed presentation or later on. The neonatal life, they can present with the neonatal bowel obstruction, delayed passage of meconium more than 24 to 48 hours, or meconium plug syndrome. Later in life, which is not very common, can present with severe failure to thrive, severe abdominal distension and constipation, and sepsis secondary to enterocolitis. It's a picture of a new infant with the Hirschsprung disease. As you can see, the the intestine and the abdomen is distended. Trisomy 21 is a risk factor for Hirschsprung disease as well. X-ray of an infant showing dilated lobes of small bowel and colon suggestive of distal bowel obstruction. Hirschsprung disease should be part of the differential. This is a contrast enema in a child with meconium plug syndrome or small left colon syndrome. As you can see, there is plugs in the meconium plug in the colon, left colon. Typically, the patient will pass the meconium plug after the contrast enema. Differential diagnosis includes Hirschsprung disease in those patients, and rectal biopsy is recommended. History, it's very important to know when the patient passed the first meconium. Any family history of Hirschsprung disease, the picture of the abdominal distension, is the baby thriving or failing to thrive, symptoms of constipation, prenatal history, ask about maternal hypothyroidism and other medication use. Radiological diagnosis include abdominal X-rays and pathological diagnosis including biopsy. So X-rays include this abdominal X-ray showed dilated lobes of small bowel and colon, suggestive of distal bowel obstruction. As we said, Hirschsprung disease should be part of the differential in infancy. Contrast enema is done by injecting water-soluble contrast into the rectum through the anal canal using a tube. As you can see, the rectum and the colon is demonstrated here. The rectum, the rectal diameter is smaller than the colonic diameter, which is suggestive of Hirschsprung disease. This is the possible transition zone at the rectosigmoid junction. Another contrast enema showing again dilated proximal sigmoid colon, distal and collapsed distal sigmoid and rectum, what's so-called reverse colorectal ratio, where the colon sigmoid colon diameter is bigger than the rectum, suggestive of Hirschsprung disease. And the possible transition zone is right here at the distal sigmoid. So the abnormal part is the contracted part of the rectum and the colon, and the dilated segment is actually the normal part. It's as we said, it's a physiological or a functional bowel obstruction. This area is failing to relax, causing obstruction to the proximal part, which is having difficulty pushing the content distally. Pathology is confirmed by doing rectal biopsy, and as you see, this is the suction rectal biopsy device, which can be used in infancy. The tip has a side hole here that we insert the tip into the rectum about 2 to 4 centimeters above the anal verge, and after applying suction, the mucosa and the submucosa will go inside the side hole, and when you pull the trigger, the blade will go and cut this specimen, and the specimen will send for pathology. In older kids, we do full thickness rectal biopsy under GA. The pathologist will look for ganglion cell. As you can see, this is normal rectal biopsy specimen, and the presence of ganglion cell rules out Hirschsprung disease. On the other hand, absence of ganglion cell confirms the diagnosis, but that can be difficult sometimes to identify. So we use other pathological findings, such as peripheral nerve hypertrophy. As you can see in this specimen, there is absence of ganglion cell and peripheral nerve hypertrophy suggestive of Hirschsprung disease, compared to normal ganglion cell and normal nerve hypertrophy in this normal specimen. Immunohistochemistry plays an important role as well. This is acetylcholinesterase enzyme immunohistochemistry. As you can see, there is normal nerve cells and normal acetylcholinesterase, suggestive of no nerve hypertrophy. Carotinin again is another stain used to look for ganglion cell. As you can see, there is normal ganglion cell throughout this rectal biopsy device, which is normal. So the diagnosis is the gold standard is absence of ganglion cell. Supportive findings such as nerve hypertrophy, peripheral nerve hypertrophy, increased acetylcholinesterase enzyme, and absence of ganglion cell by the calrotenin test. Types of Hirschsprung disease can be short segment, about 85% of cases, which involves the rectosigmoid area. The long segment in about 10% involves usually the proximal part of the colon, transverse or hepatic flexure, or total colonic in about 5% of cases, and usually familial. How to treat a patient with confirmed diagnosis? We start rectal irrigation until the day of the operation, and we teach the family how to use it. The principle of the surgery is resect the aganglionic segment and pull the new healthy colon or bowel through the anal sphincter and create coloanal anastomosis. So bringing the new colon as a new rectum. There are 3 different pull-through procedures: Swenson's, Suave, and Duhamel's. Swenson described his procedure in 1948. The procedure involves complete dissection of the rectum circumferentially and pulling the new healthy colon as a new rectum and creating coloanal anastomosis. Compared to Duhamel, who described the procedure by limiting the dissection posteriorly behind the rectum to minimize injury to the nerve fibers anterior to the rectum that supplies the bladder, and pulling the new colon, healthy colon, posteriorly at the level of the anal canal and creating side-to-side anastomosis between the old rectum and the new healthy colon. Suave described his procedure in 1960, where he limited the dissection into the rectal wall between the layers of the submucosa and the muscularis propria of the rectal wall to minimize injury to the nerve fibers anterior and posterior to the rectal wall. Then pulling the new rectum through the rectal wall and creating coloanal anastomosis. The residual muscle cuff he divides posteriorly to minimize the risk of obstruction or stenosis at the distal rectum. This is diagram of the anal canal. This is the dentate line. The dissection, the idea of the pull through is to start the dissection half a centimeter to about 1 centimeter above the dentate line to preserve the sensation of the anal canal and preserve the external anal sphincter. So the dissection will start here, whether full thickness or between the layers of the submucosa and the muscularis propria, right here, circumferentially. The procedure can be done transabdominal or transanal. For the Swenson and the Suave, Duhamel procedure usually combine transabdominal and with the transanal component. This is first of all, you expose the anal canal. You mark the site of the dissection just above the dentate line, and then you start the dissection of the old rectum all the way up to the abdominal cavity, and then pull the unhealthy part of the rectum out and create a new anastomosis. Postoperative complication include stricture at the level of the anastomosis. Typically we start dilatation, anal dilation post 3 to 4 weeks post-op to prevent stricture. Constipation is very common among Hirschsprung patients, and usually they require some sort of laxative. Patient with persistent distal bowel obstruction post pull through, we have to think about retained agangliontic segment that was not resected during the pull through procedure, internal anal sphincter achalasia, retained muscle cuff in Suave pull through, and twisted pull through. It's very rare but can happen sometimes. So the surgeon have to keep those complications in mind and look for them. Bacterial enterocolitis or Hirschsprung enterocolitis is always there is a risk for them to happen, and doing the pull through will reduce the risk but does not prevent it completely. So the family has to be informed that whenever the patient becomes sick, to bring him to the emergency department or the clinic. Thanks.